Currently, nearly 500 million adults have diabetes, and a 50% increase is expected in another generation. I've got tons of videos on the best diets for diabetes, but what about no diet at all? More than a century ago, fasting was said to bring about the cure of diabetes, speedily arresting its development and causing complete disappearance of all its manifestations in several days or weeks. Even so, starvation is guaranteed to lead to the complete disappearance of you if kept up long enough. What's the point of fasting it away if it's just going to come raging back as soon as you restart the diet that caused it in the first place? Might it be useful to kind of kickstart a healthier diet? Let's see what the science says. Type 2 diabetes has long been recognized as a disease of excess, a disease of the idle rich, by which they mean anyone who doesn't practice sustained, vigorous bodily exertion every day and earning enough to regularly eat more than they need. So diabetes is preventable, but then maybe it's also treatable. If we are dying of overeating, maybe we can be saved by undereating. Remarkably, this was suggested about 2,000 years ago in an Ayurvedic text. Diabetics were encouraged to live like a saint, walk for 800 or 900 miles, dig a pond, or live only on cow dung and cow urine. That reminds me of the Rollo diet for diabetes, proposed in 1797, composed of a diet of rancid meat that was on top of the ipecac-like drugs he used to produce severe sickness and vomiting. Anything that produces sickness has a temporary effect in relieving diabetes by diminishing the quantity of food eaten, and his diet plan, congealed blood for lunch and spoiled meat for dinner, certainly had that effect. Similar benefits were seen in diabetics during the Siege of Paris in the Franco-Prussian War, leading to the advice to manger le moins possible, eat as little as possible. That was formalized into the Allen starvation treatment, considered to be the greatest medical advance in the treatment of diabetes prior to the discovery of insulin. Before insulin, there was the Allen era. He noted reports in the clinical literature of even severe diabetics clearing up on wasting diseases like tuberculosis, so he decided to put it to the test. He found that even the most severe types of diabetes, he could clear sugar from people's urine within 10 days. Of course, that's the easy part. It's maintaining it once you start eating again, for which he stuck to two principles: keeping them underweight and restricting the quantity of fat. A severe diabetic can be symptom-free for days or weeks, but add some butter or olive oil, and the disease can come raging back. As I've covered before, diabetes is a disease of fat toxicity. Infuse fat into people's veins through an IV, and by using a high-tech type of MRI scanner, you can show in real time the buildup of fat in muscle cells within hours, accompanied by an increase in insulin resistance. The same thing happens when you put people on a high-fat diet for 3 days, or even just 1 day. Or even just a single meal can increase insulin resistance within 6 hours. Acute dietary fat intake rapidly increases insulin resistance. Why do we care? Because insulin resistance in our muscles, in the context of too many calories, leads to the buildup of liver fat, which leads to the buildup of fat in the pancreas, which is eventually what causes diabetes. Type 2 diabetes can now be understood as a state of excess fat in the liver and pancreas, and remains reversible for at least 10 years in most individuals. Put people on a very low-calorie diet, 700 calories a day, and fat can get sucked out of your muscle cells, and you get a corresponding boost in insulin sensitivity. Fat is then sucked out of your liver, and if you keep it up, the fat gets sucked out of your pancreas, and if you can catch it early enough, that can mean a reversal of your type 2 diabetes, meaning normal sugars on a normal diet. With a loss of 15% of body weight, nearly 90% of those who've had type 2 diabetes for less than 4 years can achieve remission, where it may only be reversible in 50% of those who've lived with the disease for longer than 8 years. That's better than bariatric surgery, where those losing even more weight only got 62 and 26% remissions. Right? Your forks are better than the surgeon's knives. Here's how much weight you have to lose to achieve various remission rates for those who've had diabetes for an average of 3 years. Lose about 30 pounds, and most newly diagnosed type 2 diabetics can reverse their disease. So an extended bout of physician-supervised water-only fasting could get you there, but you have to maintain the weight loss. One of the things we can say with certainty is that if you regain the weight, you regain your diabetes. To bring it full circle, the initial euphoria about medicine's greatest miracle, the discovery of insulin in 1921, soon gave way to the realization that while it was literally a lifesaver for type 1 diabetics, the use of insulin on its own in type 2 diabetics would not be enough to prevent the later onset of complications like kidney failure, blindness, stroke, amputation. So, as argued by one of the most famous diabetes pioneers, Elliot Joslin, self-discipline on diet and exercise, as it was in the days prior to insulin, should be central to the management of diabetes. On the standard American diet, atherosclerosis, hardening of the arteries, the #1 killer of men and women, starts in your teens. Investigators collected about 3,000 sets of coronary arteries and aortas, the main artery in the body, from accident, homicide, and suicide victims, 15 to 34 years of age. And this is what they found. The fatty streaks start in our teens, which turn into atherosclerotic plaques in our 20s, which get worse in our 30s, and can then start killing us off. In our heart, it can cause a heart attack. In our brain, it can cause a stroke. How common is this? 100% of the teens they looked at already had fatty streaks building up inside their arteries, and by their early 30s, most already had streaks blossoming into atherosclerotic plaques bulging into their arteries. This is what their aortas look like at ages 15 through 19. Fatty streaks building up throughout, but no plaques yet on average. But the plaques start appearing in their early 20s, and get worse in their late 20s, by which time fatty streaks have infiltrated throughout, and by our early 30s our arteries are in bad shape. But that's our aorta, the main artery that plunges down through our torso to split off into our legs. What about the coronary arteries feeding our heart? Same thing. We start out with fatty streaks in our teens, begin to see the first hint of plaque in our early 20s, then late 20s, then look at the average coronary arteries of 30 to 34-year-olds. Most people in their early 30s already have plaques in their coronary arteries. Atherosclerosis begins in youth. So that's why we shouldn't wait until heart disease becomes symptomatic to treat it. If it starts in youth, we should start treating it in youth. It's like if you knew you had a cancerous tumor, you wouldn't want to wait until it grew to a certain size to treat it, or if you had diabetes, you wouldn't want to wait until you started going blind before you did something about it. OK, so how do you treat atherosclerosis? You lower LDL cholesterol through a stringent diet that's low in cholesterol and saturated fat, so a diet that's low in eggs, meat, dairy, and junk. If we want to stop this epidemic, we have to alter our lifestyle accordingly, starting as early as possible. Is such a radical proposal totally impractical? I mean, eating more healthfully? Radical. It would, of course, take an all-out commitment, but remember, this is our #1 cause of death. I mean, if you're going to commit to anything, we did pretty good with cigarettes, slashing smoking rates, and lung cancer rates came right down. And yes, healthy eating is safe. According to the Academy of Nutrition and Dietetics, the largest and oldest association of nutrition professionals in the world, even strictly plant-based diets are appropriate for all stages of the lifestyle, from pregnancy, infancy, through old age. And if you want to learn more, the Academy can suggest a few good websites to visit. Curing atherosclerosis should be the next major cardiovascular prevention goal. What evidence do we have that a lifelong suppression of LDL will do it? There's a genetic mutation of a gene called PCSK9 that about 1 in 50 African Americans are lucky to be born with because it gives them about a 40% lower cholesterol their whole lives. And indeed, They have dramatically lower rates of coronary artery disease to show for it, an 88% drop in risk, despite otherwise terrible risk factors on average. Most had high blood pressure and were overweight, almost a third smoked, nearly 20% had diabetes. But that just goes to show that a lifelong history of reduced LDL cholesterol levels significantly lowers the risk of coronary heart disease, even in the presence of multiple risk factors. And this near 90% drop in events like heart attacks or sudden death occurred at an average LDL of 100 compared to 138. So you could get even lower than 100. Hold on. Why does the lowering of LDL cholesterol by about 40 points in those with that lucky genetic mutation reduce heart disease incidence by nearly 90%, whereas that same 40-point drop with statin drugs would reduce heart disease by only about 20%? The most likely answer is duration. When it comes to lowering LDL cholesterol, it's not only how low, but how long it's been low. That's why healthy lifestyle choices may wipe out like 90% of our risk for having a heart attack, whereas drugs may reduce it only by 20 to 30%. If you're getting treated with drugs later in life, you may have to get your LDL under 70 to halt the progression of coronary atherosclerosis. But if we start early enough, young enough, it may be sufficient to just lower LDL cholesterol down to 100, which should be attainable for most people. That's consistent with country-by-country data that suggests that heart disease would bottom out at a population average of about 100. But that's if you can keep it down your whole life. If you're just using drugs late in life to try to stop the progression of your disease, you have to get your LDL lower than 70. And if you're trying to use drugs to reverse a lifetime of bad food choices, you don't get to zero until about an LDL of 55. And if your heart disease is so bad you've already had a heart attack, but you're trying not to die from another one, ideally you might want to push your LDL down to about 30. Now, once you get that low, not only would you prevent any new atherosclerotic plaques, but you'd also help stabilize the plaques you already have, so they're less likely to burst open and kill you. Is it even safe to have cholesterol levels that low, though? In other words, can LDL cholesterol ever be too low? We'll find out next. Extrapolating down the graphs from large cholesterol-lowering trials using statin drugs suggests that the incidence of cardiovascular events like heart attacks would approach zero if the LDL cholesterol can be forced down below 60 in preventing one's first heart attack, and down around 30 for those trying to prevent another one. But is lower actually better, and is it even safe to have cholesterol levels that low? We didn't know until PCSK9 inhibitors were invented. If that word sounds vaguely familiar, it's because that was the gene I profiled in the last video. It's the one that got mutated to give people such low LDL, and indeed that's how Big Pharma came up with the idea of trying to instead cripple PCSK9 with drugs. After a heart attack, intensive LDL cholesterol lowering beyond a target of 70 does seem to work better. There were fewer cardiovascular deaths, heart attacks, or strokes at an LDL less than 30 compared with 70 or higher, even compared to less than 70. There's a consistent risk reduction even when starting as low as an average of 63. And pushing LDL down to 21, remarkably, showed no observed offsetting adverse side effects. Maybe that shouldn't be so surprising, given that that's about what the level at which we start out life. And there's another type of genetic mutation that leaves people with LDLs of about 30 their whole lives, and they are known to have an exceptionally long life expectancy. Then wait, where did we get this idea that cholesterol could fall too low? The often repeated suggestion that cholesterol lowering can be dangerous through depletion of cell cholesterol is unsupported by evidence, and does not take into account the exquisite balancing mechanisms our body uses. After all, remember, that's how we evolved. Until recently, most of us used to be running around with LDLs around 50, so that's like normal for the human species. The absence of proof that low or lowered cholesterol levels are somehow bad for you contrasts with the substantial evidence that cholesterol reduction prevents coronary artery disease, our #1 killer. What about hormone production, though. And since the human body needs cholesterol for synthesis of steroid hormones like adrenal hormones, sex hormones, there's a concern that there wouldn't be enough. You don't know, though, until you put it to the test. For decades, we've known that women on cholesterol-lowering drugs don't have a problem with estrogen production, nor does cholesterol lowering affect adrenal gland function, nor does it impair testicular function in terms of the production of testosterone. If anything, statin drugs improve erectile function in men, which is what you'd expect from cholesterol lowering. But you'll notice that these studies only looked at getting LDL down to 70 or below. What about really low LDL? On PCSK9 inhibitors, you can get most people under an LDL of 40, and some under 15, and no evidence of impairment of adrenal or ovarian or testicular hormone synthesis, even in patients with LDL levels under 15. The risk of heart attacks falls down in a straight line as LDL gets lower and lower, even down below 10, for example, without apparent safety concerns. But that's over the duration of exposure to these drugs. The longest follow-up to date is about 6 years, using multiple medications to drop LDL as low as possible. Now, we can take comfort in the fact that those with extreme PCSK9 mutations leading to a lifelong reduction in levels of LDL to under 20 their whole lives remain healthy and have healthy kids. Cholesterol-affecting mutations are in fact what cause the so-called longevity syndromes. But that doesn't necessarily mean the drugs are safe. The bottom line is we should try to get our LDL cholesterol down as low as we can. But much longer follow-up data are necessary anytime a new class of drugs is introduced. So far, so good, but we're only a few years out. For example, we didn't know statins increased diabetes risk until decades after they were approved and millions had been exposed. And not to mention, PCSK9 inhibitors cost about $14,000 a year. How do you rate the quality of people's diets? Well, what could be more nutrient-dense than a vegetarian diet? Indeed, if you compare the quality of vegetarian diets compared to non-vegetarian diets, the more plant-based diets do tend to win out, and the higher diet quality in vegetarian diets may in fact help explain better improvements in health outcomes. However, vegetarians appear to have higher refined grain intake, eating more foods like white rice and white bread that have been stripped of much of their nutrition. So just because you're eating a vegetarian diet doesn't mean you're necessarily eating optimally healthy. Those familiar with the science know the primary health importance of eating whole plant food. So how about a scoring system that just adds up how many cups of fruit, vegetables, whole grains, and beans, split peas, chickpeas, and lentils, and how many ounces of nuts and seeds per 1,000 calories, with or without counting white potatoes? Well, just looking at the total intake of whole plant foods doesn't mean you're not also stuffing donuts into your face. So you can imagine proportional intake measures based on calories or weight to determine the proportion of your diet that's whole plant foods. In that case, you'd get docked points if you eat things like animal-derived foods, meat, dairy, or eggs, or added sugars and fats. My favorite proportional intake measure is McCarty's Phytochemical Index, which I've profiled previously. I love it because its sheer simplicity, defined as the percent of dietary calories derived from foods rich in phytochemicals. So it's a score from 0 to 100, the percentage of your calories that are derived from foods rich in phytochemicals, which are biologically active substances naturally found in plants that may be contributing to many of the health benefits obtained from eating whole plant foods. I mean, monitoring phytochemical intake in the clinical setting could have great utility in assisting people with optimizing their dietary intake for optimal health and disease prevention. However, the quantification of phytochemicals in foods or tissue samples is impractical, expensive, laborious. But hey, this concept of a phytochemical index score could be an alternative, simple method of monitoring phytochemical intake. Theoretically, a whole food plant-based or vegan diet that excluded refined grains, white potatoes, hard liquors, and added sugars and oils could achieve a perfect score of 100, whereas sadly, the most current American diets might be lucky to hit 20. Let's see what's going on. In 1998, our shopping baskets were filled with about 20% whole plant foods, and more recently that has actually shrunk. Wouldn't it be interesting if researchers used this index to try to correlate it with health outcomes? That's exactly what they did. Look, we know that studies have demonstrated vegetarian diets have a protective association with weight and body mass index. 5 dozen studies have shown that vegetarians had significantly lower weight and BMI compared with non-vegetarians. And even more studies show that high intakes of fruits, vegetables, whole grains, and beans may be protective regardless of meat consumption. So researchers wanted to use an index that gave points for whole plant foods. They used a phytochemical index and tracked people's weight over the next few years, which, again, I profiled in my video, Calculate Your Healthy Eating Score, on a scale of 0 to 100, simply reflecting what percentage of your diet is whole plant foods. And even though the healthiest eating tier only averaged a score of about 40, which meant the bulk of their diet was still made up of processed foods and animal products, just making whole plant foods a substantial portion of the diet may prevent weight gain and decrease body fat. So it's not all or nothing. Any steps we can make to increase our whole plant food intake may be beneficial. A couple more studies have been performed since, and they all point in the same direction. About a third of the odds of abdominal obesity at higher healthy plant intake, and significantly lower odds of high triglycerides. So the index may be a useful dietary target for weight loss, where there's less focus on calorie intake and more on increasing intake of these high-nutrient, lower-calorie foods over time. The latest such study, published 2020, suggests the same is true for childhood obesity. Even at the same weight, the same amount of belly fat, those eating plant-based have higher insulin sensitivity, meaning the insulin they make works better in their body, perhaps thanks to the compounds in plants that alleviate inflammation and quench free radicals. And indeed, things seem to improve as people ate more and more plants. No wonder researchers found 91% lower odds of prediabetes for people getting more than half their calories from healthy plant foods. Significantly lower odds of metabolic syndrome and high blood pressure, only about half the odds of being diagnosed with hypertension over a 3-year period among those eating more plants. Even mental health was impacted. About 80% less depression, 2/3 less anxiety, 70% less psychological distress. What about the dietary phytochemical index in benign breast diseases, such as fibrocystic diseases, ductal fatty necrosis, and all sorts of benign tumors? The same thing was found, 70% lower odds of those diseases. OK, but what about breast cancer? A higher intake of healthy plant foods was indeed associated with a lower risk of breast cancer, even after controlling for a long list of other factors, and not just by a little bit. Eating twice the proportion of plants compared to the standard American diet was linked to more than 90% lower odds of breast cancer. Intestinal permeability, the leakiness of our gut, may be a new target for disease prevention and therapy. With all of its little folds, our intestinal barrier covers a surface of more than 4,000 square feet. That's bigger than a tennis court, and requires approximately 40% of our body's total energy expenditure to maintain. Mounting evidence implicates the disruption of intestinal barrier integrity in the development of numerous ailments, such as inflammatory bowel disease. Here, researchers measured intestinal permeability using blue food coloring. It stays in your gut if you're healthy, but can be detected in the blood of extremely sick individuals as their gut barrier breaks down. You don't have to end up in the ICU to develop a leaky gut, though. Simply taking some aspirin or ibuprofen can do the trick. Indeed, taking 2 regular aspirin or 2 extra-strength aspirin just once can increase the leakiness of your gut. These results suggest even healthy individuals should be cautious with aspirin use, as it may result in gastrointestinal barrier dysfunction. What about buffered aspirin? It doesn't make any difference. Both regular aspirin and bufferin produced multiple erosions in the inner lining of the stomach and intestines. Put a scope down people's throats, and you can see extensive erosions and redness inside 90% of people taking aspirin or bufferin in their recommended doses. How many hours does it take for the damage to occur? None. It happens within 5 minutes. Acetaminophen, sold as Tylenol in the U.S., would be a better choice, unless you have problems with your liver. And rather than making things better, vitamin C supplements appeared to make the aspirin-induced increase in gut leakiness even worse. Interestingly, this may be why NSAID drugs like aspirin, ibuprofen, and naproxen are involved in up to 25% of food-induced anaphylaxis. In other words, increasing the odds of life-threatening food allergy attacks by more than tenfold, presumably because these drugs increase the leakiness of the intestinal barrier, causing tiny food particles to slip into the bloodstream. OK, but why can exercise increase risk too? Strenuous exercise, like an hour at 70% of maximum capacity, can divert so much blood to the muscles away from your internal organs that it can cause transient injury to your intestines, causing mild gut leakiness. But this can be aggravated if athletes take ibuprofen or any of the other NSAID drugs, which is unfortunately all too common. Alcohol can also be a risk factor for food allergy attacks for the same reason, increasing gut leakiness. But cut out the alcohol, and your gut can heal up. What other dietary components can make a difference? Elevated consumption of saturated fat, which is found in meat, dairy, and junk, can cause the growth of bad bacteria, which make the rotten egg gas hydrogen sulfide, which can degrade the protective mucus layer. It is said to be clear that high-fat diets in general negatively impact intestinal health by disrupting the intestinal barrier system through a variety of mechanisms, but most of the vast array of studies cited on the negative effects of high-fat diet on gut leakiness were done on lab animals or in a petri dish. You don't know for sure until you put it to the test. Rates of obesity and other cardiometabolic disorders have increased rapidly in parallel with a transition from traditional lower-fat diets to higher-fat diets. We know a disturbance in our good gut flora has been shown to be associated with a high risk of many of these same diseases, and studies using rodents suggest that a high-fat diet unbalances the microbiome and impairs the gut barrier, resulting in disease. To connect all the dots, though, we need a human interventional trial, and here we go, a 6-month, randomized controlled feeding trial on the effects of dietary fat on gut microbiota, and indeed, higher fat consumption appeared to be associated with unfavorable changes in the gut microbiome and pro-inflammatory factors in the blood. And note, this wasn't meat and dairy. The researchers just swapped in refined carbs in place of refined fats, like white rice and white flour, for oil. These findings suggest countries westernizing their diets should advise against increasing intakes of dietary fat, while countries that have already adopted westernized diets should consider cutting down. So far, we've discussed things to prevent a leaky gut. What about foods to heal a leaky gut? That's what we'll cover next. Our intestinal tract is the largest barrier between us and the environment. More than what we touch or breathe, what we eat is our largest exposure to the outside world. Normally, our entire gastrointestinal tract is impervious to what is inside of it, allowing our body to pick and choose what comes in or out. But there are things that may make our gut leaky, and chief among them is our diet. What happens is the standard American diet can cause gut dysbiosis, meaning a disruption in our gut microbiome, which can lead to intestinal inflammation and a leaky intestinal barrier. Then tiny bits of undigested food, microbes, and toxins can slip uninvited through our gut lining into our bloodstream and trigger chronic systemic inflammation. To avoid this dysbiosis and intestinal inflammation, plants should be preferred. Vegetarian diet gut bacteria are associated with intestinal microbiome balance, high bacterial biodiversity, and integrity of the intestinal barrier. They tend to suffer from markedly fewer uremic toxins like indole and P. cresol, and because fiber is the primary food for our gut microbiome, the gut bacteria of those eating plant-based diets produce more of the good stuff, the short-chain fatty acids that fulfill a protective and nourishing role for the cells lining our gut, ensuring the preservation of the intestinal barrier. Plant fiber is of prime importance to the preservation of intestinal barrier integrity, but you can't know for sure until you put it to the test. People were given whole grains, beans and lentils, fruits, vegetables, and nuts and seeds, and got a significant reduction in zonulin levels. Zonulin is a protein responsible for the disassembling of the tight junctions between gut lining cells, and so it's a biomarker that reflects an impairment of the intestinal barrier. In other words, zonulin is considered to be a useful marker of a leaky gut. But since adding all those plants seem to lower levels, that may imply that appropriate fiber intake helps to maintain the proper structure and function of the intestinal barrier. But whole, healthy plant foods have a lot more than fiber. How do we know it's the fiber? And the study didn't even have a control group. That's why they say gut permeability might be improved by dietary fiber. To prove cause and effect, it'd be nice to have a randomized, double-blind crossover study where you compare the effect of the same food with or without fiber, and here we go. People were randomized to pasta with or without added fiber, and there was a significant drop in zonulin levels in the added fiber group, so fiber does appear to improve gut leakiness. Any plant foods in particular that may help? Curcumin, the yellow pigment in the spice turmeric, can help prevent the intestinal damage done by ibuprofen-type drugs, but that's in rats. Similar protection was noted for the broccoli compound sulforaphane, but that was in mice. No human studies on broccoli yet, but there was a study on 3 days of the equivalent of about 2 to 3 teaspoons a day of turmeric, which did reduce the gastrointestinal barrier damage caused by exercise. Less may work too, but no smaller doses have been put to the test. If you ask alternative medicine practitioners what treatments they use for a leaky gut, number 1 on the list, after reducing alcohol consumption, is zinc. Zinc doesn't just protect against aspirin-like drug-induced damage in rats. When put to the test in a randomized trial of humans, the same thing was found. The NSAID drug indomethacin caused a 3-fold rise in gut permeability, as one would expect from that class of drugs. But when they were also taking zinc, this prevented the rise in permeability, strongly suggesting a small intestinal protective effect. The dose they used was massive, though, 75 milligrams a day. That's nearly twice the tolerable upper daily limit for zinc. What about getting zinc just at regular food doses? There was a significant improvement in gut leakiness, even with a dose of just 3 milligrams of zinc, suggesting that even relatively low zinc supplementation may work. You can get 3 extra milligrams of zinc in your daily diet eating a cup of cooked lentils. In 2013, I can't believe it's already been so long, I posted a video based on this study that found that 3 weeks of pistachios resulted in a significant improvement in erectile function in men. It's always nice to see a whole food intervention have clinical effects, and I was curious to revisit the topic to see what's been published since. Even if you ignore all the lab animal studies on how much hazelnuts improve the function of rat testicles, you still never know what you'll find searching the medical literature for nuts and sexual function. Like this case of penile strangulation with a metal hex nut. I guess nuts can sometimes make things worse, if you can't remove them. They used the Dundee technique, which involves creating 20 puncture holes to relieve the pressure, but that didn't work, so a diamond disc cutter was used to saw through it, and they slipped a few times. All's well that ends well. Well, that got me curious. Evidently, penile entrapment is so common, there's an entire grading system that emergency room docs can use. If a drill is not available, the surgeons advise a hammer and chisel may be used. A drill? Oh, a dental drill. I like how they brag about the precisely cut edges. Looks pretty jagged to me. To preserve the penis from a fatal outcome, that's a strange way to put it, urologists should be aware of all the available armamentarium. And if you don't know how to operate the saw, you can always call in your local blacksmith. Yeah, but how are you going to remove a barbell or steel sledgehammer head? A heavy-duty air grinder provided by the fire department, requiring 6 hours of cutting with the patient protected from the sparks with fire coats, whatever it takes, hacksaw, cement eater, or the silk winding method. But anyway, back to the task at hand. Consumption of at least 1 serving of vegetables a day and more than 2 servings of nuts a week was associated with more than a 50% decrease in the probability of erectile dysfunction in a snapshot-in-time cross-sectional study, but such observational studies can't prove cause and effect. It's like finding that men who eat more healthfully have better swimmers. Maybe men who eat nuts are just health nuts, and the improvement is due to some other factor, like exercise. Oh, what we need is an interventional trial, and here we go. The effect of nut consumption on semen quality and functionality, a randomized controlled trial, a standard American diet with or without a handful of walnuts and a half-handful of each almonds and hazelnuts. And the nut group experienced significant improvements in their total sperm count, vitality, motility, and shape, perhaps because those in the nut group showed a significant reduction in SDF, sperm DNA fragmentation. The nuts appeared to protect their sperm DNA. Too bad while they're at it, they didn't measure the guy's erectile and sexual dysfunction. Oh, but they did! The effect of nut consumption on erectile and sexual function from the same study, the researchers report that those in the nut group saw a significant increase in orgasmic function and sexual desire. But what about erectile function? Anytime you see this kind of selective glass-half-full reporting, you suspect some kind of industry funding, and indeed that was the case here. Yes, there was a marginal increase in orgasmic function and sexual desire of questionable clinical significance, but no improvement in erectile function, intercourse satisfaction, or overall satisfaction. And with so many comparisons, even the so-called significant findings may not even be statistically significant. But why did the pistachios I talked about back in 2013 work, while these other nuts didn't? Well, if you remember, the original study was done on men in their 40s and 50s who already had chronic erectile dysfunction, whereas the average age in the new study was 24 years old. So they may have started out with near maximum circulation, not leaving much room for the nuts. Intragastric balloons arrived with much fanfare in the 1980s, balloons that could be implanted into the stomach and inflated with air or water to fill up much of the space. Sadly, surgical devices are often brought to the market before there's adequate evidence of safety and effectiveness, and the balloons were no exception. The gastric bubble had its bubble burst when a study at the Mayo Clinic found that 8 out of 10 balloons spontaneously deflated, which is potentially dangerous as they could pass in the intestines and cause an obstruction, but not before causing gastric erosions in half the patients, damaging the stomach lining. The kicker is that in terms of inducing weight loss, it didn't even work. Eventually, it was pulled from the market, but now balloons are back. After a 33-year hiatus, the FDA started approving a whole slew of intragastric balloons in 2015, immediately resulting in more than 5,000 placements. By then, the Sunshine Act had passed, which forced drug companies in the surgical and medical device industry to disclose any payments they were making to physicians to shine a disinfecting light on industry enticements. By now, most people know about the overly cozy financial relationship doctors can have with Big Pharma, but fewer may realize that surgeons can also get payments from companies for the devices they use. The 100 top recipients of industry payments received an unbelievable $12 million from device companies in a single year. Yet outrageously, when they published papers, only a minority disclosed the blatant conflict of interest. The benefit of balloons over most types of bariatric surgery is that they're reversible, but that doesn't mean they're benign. The FDA has released a series of advisories about the risks that include patient deaths. Wait, how could someone suffer a stomach perforation with a smooth, rounded object? By causing the patient to puke so much, they rupture their stomach and die. That's how. Nausea and vomiting are unsurprisingly very common side effects, affecting the majority of those who have balloons placed inside them. Persistent vomiting likely also explains cases of life-threatening nutrient deficiencies after balloon implantation. Some complications, such as bowel obstruction, are due to the balloon deflating, but others, oddly enough, are due to the balloons suddenly overinflating, causing pain, vomiting, and abdominal distension. This was first noticed in breast implants, as documented in reports such as the phenomenon of the spontaneously auto-inflating breast implant. Out of nowhere, the implants just start growing, increasing breast volume by an average of more than 50%. It remains, one review noted, an underreported and poorly understood phenomenon. Interestingly, breast implants were actually used as some of the first failed experimental intragastric balloons. As with any medical decision, though, it's all about risks versus benefits. Industry-funded trials display notable weight loss, but it's hard to tease out the effect of the balloon alone from the accompanying supervised diet and lifestyle changes prescribed along with them in the studies. In drug trials, you can randomize subjects to sugar pills, but how do you eliminate the placebo effect of undergoing a procedure? Perform sham surgery. In 2002, a courageous study was published in the New England Journal of Medicine. The most common orthopedic surgery, arthroscopic surgery of the knee, was put to the test. Billions of dollars are spent sticking scopes into knee joints and cutting away damaged tissue in osteoarthritis and knee injuries. But does it actually work? Knee pain sufferers were randomized to get the actual surgery versus a sham surgery, in which they actually sliced into people's knees and pretended to perform the procedure, complete with splashing saline, but never actually did anything within the joint. The trial caused an uproar. How could you randomize people to get cut open for fake surgery? Professional medical associations questioned the ethics of the surgeons, as well as the sanity of the patients who agreed to be part of the trial. But guess what happened? Sure, the surgical patients got better, but so did the placebo patients. The surgeries had no actual effect. Currently, rotator cuff shoulder surgery is facing the same crisis of confidence. When intragastric balloons were put to the test, sham-controlled trials show both older and newer devices sometimes fail to offer any weight loss benefit. Even when they do work, the weight loss may be temporary, because balloons are only allowed to stay in for 6 months, at which point the deflation risk gets too great. Why can't you just keep putting new ones in? That's been tried, and failed to improve long-term weight outcomes. A sham-controlled trial showed that any effects of the balloon on appetite and satiety may vanish with time, perhaps as your body gets used to the new normal. What sham surgery trials have shown us is that some of our most popular surgeries are themselves shams. Doctors like to pride themselves on being men and women of science. We rightly rail, for example, against the anti-vaccination movement. Many of us in medicine have been troubled by the political trend of people choosing their own facts. But when I read that some of these still popular surgeries are not only useless, but may actually make things worse, for example, increasing the risk of progression to a total knee replacement, I can't help but think we are hardly immune to our own versions of fake news and alternative facts. A moderately obese person doing moderately intense physical activity like biking or brisk walking would burn off approximately 350 calories an hour, but most drinks, snacks, and other processed junk are consumed at a rate of about 70 calories per minute. Therefore, it only takes 5 minutes for someone to wipe out a whole hour of exercise. Enter the Aspire Assist Siphon Assembly. It's a percutaneous gastrostomy device, meaning surgeons cut a hole in your stomach and tunnel a fistula out through your abdominal wall. So after each meal, you can attach a suctioning gadget to the hole and directly drain out your stomach contents. You could gorge on donuts, spew them out through the hole in your stomach, and then gorge again on even more donuts. Have your cake and eat it too. And 3 and 4 times. It's like bulimia without the aftertaste. Seems to be the quintessential American invention, straight from the land that brought you Jell-O salads, spray cheese, and deep-fried Snickers bars. Patients do lose weight, perhaps in part because the fistula may interfere with the relaxation of the stomach wall during a meal. The process also requires drinking lots of water and for food to be chewed thoroughly, both of which may help with weight loss in other ways, by increasing hydration and slowing eating rate. Patients also started to make healthier choices to avoid unpleasant-appearing gastric aspirate of unhealthy food choices. The tubing is clear, and evidently fried foods look particularly gross as they're pumped out. All patients need to take supplemental potassium, since it's sucked out in the stomach juices, otherwise they risk becoming potassium deficient, a common complication in true bulimia. But most side effects are just minor wound complications. Serious adverse effects like abdominal abscesses are rare. The big selling point is that the siphon device does not alter the anatomy of the gastrointestinal tract. Seems like a low bar, but in today's Wild West world of weight loss procedures, you can't take anything for granted. Case in point, the duodenal jejunal bypass liner. Gastric bypass surgery works in part by cutting out part of the small intestine from the flow of food to help prevent the absorption of calories. Instead of major surgery, how about just dropping down a couple feet of plastic tubing to line the intestinal walls? The problem with the endobarrier is that it has to be anchored in the digestive tract. This is accomplished with 10 barbed hooks that cause lacerations, accounting for the majority of the 891 adverse effects reported in 1,056 patients. That's nearly 9 out of 10. Severe penetrating trauma, resulting in esophageal perforation or liver abscesses, is thankfully more rare, occurring in only about 1 in 27 patients. Concern has been raised about the palatability of the AspirAssist stomach pump, but the most cringeworthy endoscopic procedure I ran across in my research was intestinal resurfacing. Why cover the inside of your intestines with plastic to prevent absorption when you can just thermally ablate the superficial duodenal mucosa? In other words, have your intestinal lining burned off, or rather resurfaced. Surgeons have tried injecting Botox into the stomach walls of obese individuals, hoping it would partially paralyze their gastric muscles, slow stomach emptying, make people feel fuller longer, and lose weight. It didn't work. Researchers in Sweden tried randomizing people to wear corsets for 12 to 16 hours a day, 7 days a week for 9 months, and it didn't work. You can guess why. The study subjects just didn't wear them. The corset was perceived as uncomfortable. Duh. Sanitized tapeworms have evidently been widely advertised as a weight loss remedy since back in the early 1900s. The fact that living tapeworms have been discovered during bariatric surgery operations suggests infesting yourself with parasites may not be particularly effective either. Speaking of disgusting strategies, how about disgust itself? A study entitled Harnessing the Power of Disgust, a randomized trial to reduce high-calorie food appeal through implicit priming, tried using subliminal messages to ruin people's appetite. Immediately before images of healthy foods, researchers showed people happy images, like a group of kittens in a 20-millisecond flash. That's too quick to consciously register, but the hope was to plant a positive imprint on the brain. Before images of high-calorie foods like ice cream, though, they instead flashed scenes of a cockroach on a slice of pizza, vomit in an unclean lavatory, a burn wound. Apparently, it worked. Subjects subsequently reported a reduced desire to eat high-calorie foods, though this wasn't tested directly. The researchers conclude subliminal revulsion may be a successful tactic to combat the onslaught of food cues that promote unhealthy eating. The rest of the world look on bemused by American machinations, penning commentaries like, "A view from across the pond, don't let them eat cake." A paper in the journal Obesity Surgery entitled "What Are the Yanks Doing?" reviewed the U.S. experience with implantable gastric stimulation, inserting electrodes into the muscular layer of the stomach wall. When that didn't work, we tried colon electrical stimulation. Even more shocking were studies like repetitive electric brain stimulation reduces food intake in humans. Though placing deep brain electrodes is considered a complication-prone operation, scientists have long pondered whether placing an electrode somewhere in the brain could make people eat less. Holes were drilled through the skulls of 5 obese individuals, and wires were pushed into their brains for electrostimulatory exploration. Once they poked around and found spots where they were able to elicit convincing hunger responses, they sent enough juice in to fry out electrocoagulatory lesions. It seemed to work in cats and monkeys, but the researchers found that burning holes in people's brains did not produce weight loss in obese humans. Thankfully, as I aim to explain in my book How Not to Diet, healthy, sustainable weight loss isn't brain surgery. In my last video on onions, I talked about the data supporting or not supporting the role of onions in boosting testosterone in men, protecting bone health, controlling allergies, and dealing with chemo side effects. What about weight loss? Enter the effect of steamed onion consumption on body fat in overweight subjects. The researchers used steamed onions so they could better disguise it against placebo, and dried it into an onion powder, and gave people just a minuscule amount, about 1/8 of a teaspoon a day. Surely a little daily dusting of onion powder isn't going to affect the course of people's weight, but check out these results. Reported in the abstract, a significant reduction in body fat mass on both DEXA scan and measured by CT scan, a significant decrease in the areas of whole fat, visceral fat, and subcutaneous fat. Hold on, if a little onion powder is so effective for weight loss, why wasn't it featured in my book, How Not to Diet? Because, as so often happens in studies, the spin in the abstract doesn't accurately represent the actual data. Here are the DEXA scan results. No significant change of fat in the group that got the placebo capsules. They only appeared to lose about a spoonful of fat, whereas the group unknowingly taking 1/8 of a teaspoon of onion powder stuffed into capsules lost nearly 1.5 pounds of body fat, a significant drop from baseline, but not a statistically significant drop compared to the placebo group, meaning the loss could very well have been due to chance. Same thing with the CT scan results, 5 times more loss of overall fat, and 30 times more loss of the dangerous visceral fat, but did not reach statistical significance compared to placebo. A more recent study tried 4 teaspoons of onion powder a day and similarly failed to accelerate the loss of body fat compared to placebo. But the placebo was also 4 teaspoons of onion powder a day. They used yellow onions versus white onions, and it seems they both may have caused a loss of body fat, without a significant difference between them. Either way, you can look at these two studies and say, yeah, but what are the downsides? I mean, just 1/8 of a teaspoon of onion powder a day, why not give it a try? Can't hurt, but we just don't have confidence that it's actually gonna help. Turning now to polycystic ovary syndrome, also known as PCOS or PCOS. It's one of the most common hormone disorders, affecting 5 to 10% of reproductive-aged women. In addition to symptoms like irregular periods, PCOS is also a pre-diabetic state with decreased insulin sensitivity. PCOS treatment is a big challenge due to medication side effects, so what about using dietary options? How about a randomized controlled clinical trial of raw red onion intake? Why onions? Well, onion extracts evidently help in diabetic rats, and more importantly in diabetic humans, but evidently not in non-diabetic humans. PCOS sufferers are kind of pre-diabetics, so would it work for them? First, let's look at those other 2 studies. Here's the diabetic one. On the metabolic effects of onion and green beans, diabetics spent a week eating either a small onion a day, or the same diet with about 5 cups of green beans instead, and they both worked. The onion group dropped people's blood sugars by about 10%, and the green beans more like 15%. Here's the study that supposedly shows no blood sugar benefits for non-diabetics. It's true, onions don't lower normal blood sugars, which is a good thing, but check out what happens when you feed people sugar. Have people down about 2 tablespoons of corn syrup, and their blood sugars shoot up over the next 2 hours before their body is able to tamp it back down. But give people the exact same amount of sugar, but with more and more onion, and the blood sugar spike is significantly dampened, almost as much as if you instead given them an anti-diabetic drug. And we see the same when you give people a shot of adrenaline, with or without onions. So while there are blood sugar benefits for both diabetics and non-diabetics alike, no difference was found between the higher and lower onion groups of PCOS patients, nor were there any differences in a marker of inflammation between the 2 groups. But women with PCOS aren't just at high risk for diabetes and inflammation, but also high cholesterol. Women with PCOS are 7 times more likely to have a heart attack, the #1 killer of women. But raw red onion consumption appears to be effective as a cholesterol-lowering food, though the high onion group only dropped their LDL cholesterol about 5 points, not significantly different than the low onion group. I did find this study from nearly 50 years ago, where researchers fed people nearly an entire stick of butter, and their cholesterol shot up about 30 points within hours of consumption, but only 9 points, or 3 points, when combined with about a 1/3 cup of raw or boiled onion. The moral of the story being, don't eat a stick of butter. Parkinson's disease is a neurodegenerative brain disorder that affects millions of people. What causes it? Well, if you look at lifestyle factors associated with Parkinson's disease, the strongest dietary association with increased risk of Parkinson's disease is dairy consumption. In fact, dairy products are the only food group that have been consistently associated with a high risk of developing Parkinson's. 5 large prospective studies have confirmed the link, including the 2 Harvard cohorts, the Harvard Nurses' Health Study and other health professionals, which followed more than 100,000 people for decades in the largest analysis of dairy and Parkinson's disease to date, analyzing more than 1,000 newly diagnosed cases, and all of the studies found a link between dairy and Parkinson's, most finding a significant link, about a 50% increased risk overall in those drinking the most milk compared to those drinking the least, at a p-value of less than 0.00001, meaning less than 1 in 100,000. You'd only get a finding that extreme by chance. OK, but why is there a link at all? Despite clear-cut associations between milk intake and Parkinson's disease incidence, there is no rational explanation, concluded one review. A year later, though, we got a clue. Midlife milk consumption and substantia nigra neuron density at death. What does that mean? Parkinson's is caused when most of the nerve cells in a critical part of the brain are killed off. So if you go back and see how much milk people were drinking in their 40s, 50s, and 60s, and then look at their brains on autopsy and count how many of these critical neurons they had left, in every single quadrant, neuron density was maximized in those who consumed no milk, and lowest in those who consumed the most milk. Even after removing the Parkinson's cases, those drinking 2 cups of milk a day had up to 40% fewer nerve cells in that critical brain region. What's in milk that could be wiping out brain cells? Among those who drank the most milk, residues of the pesticide heptachloroepoxide were found in 9 out of 10 brains. So maybe the finding of pesticide residues more commonly in the brains of those who drank the most milk could explain how milk could be cause and effect related to Parkinson's disease risk. Now, that's not the only potential explanation. Remember my video on how meat contains that clumpy neurotoxic protein alpha-synuclein? Well, dairy products may contain trace amounts as well, but we don't have confirmation of that. Could the milk sugar galactose be the missing link? That's what lactose in milk breaks down into in the body. And galactose is what's used to induce aging, to experimentally cause aging in the brain. When you drink it, the galactose is picked up by your brain within a few hours. For doses above 100 milligrams per kilogram, it appears that galactose can cause pathological alterations in brain cells similar to those observed in Parkinson's disease. And these quantities can be reached and surpassed with the simple daily consumption of 2 glasses of milk, the main dietary source of galactose in humans. And of all your brain cells, those dopaminergic neurons, the ones you need to retain to prevent Parkinson's, may be more vulnerable to galactose-induced damage, galactose-induced oxidative stress. Galactose may also explain the findings that link milk drinking with higher death rates. Now, you may be thinking, well, duh, the saturated butterfat is just cutting people's life short. But higher mortality with higher milk consumption is absorbed irrespective of the milk fat content. Skim milk might be fat-free, but it's not lactose-free. Can't you just use lactose-free milk? What about Lactaid? That has the lactase enzyme added to make lactose-free milk, but it just breaks down the lactose into galactose in the carton rather than in your gut, so you're still ingesting the same amount of galactose. Perhaps no wonder, then, that greater milk intake at midlife may be associated with greater rate of cognitive decline. I mean, researchers used galactose to create brain aging in the laboratory. Administration of D-galactose, a metabolic derivative of lactose, has been extensively used to mimic cognitive aging through oxidative stress in animal models. Compared to those who said they almost never drink milk, those drinking more than a glass a day appear more likely to suffer a global decline in their cognitive function. Personalized nutrition is rooted in the concept that one size does not fit all, and who doesn't want to think they're special? The concept of personalized nutrition is inherently appealing to the human ego. Simple messages, recognizing individuality, therefore resonate deeply with consumers, explaining the popularity of such messages in sales and marketing, even to the point of manufacturing personalized food for people's uniqueness, suggesting 3D food printing is a good candidate for food customization. Now, there certainly are some legitimate differences between people. Some have a peanut allergy and keel over if they eat a peanut, and others have celiac disease and have to avoid gluten, or genetically are lactose intolerant. There's an enzyme mutation common in some parts of Asia that protect against alcoholism, because people with it can't metabolize alcohol as efficiently, so toxic metabolites build up. I did a fascinating video about fast versus slow caffeine metabolizers and the difference in health benefits. That actually extends to athletic performance. Caffeine is ergogenic, performance-enhancing, but only in fast metabolizers, shaving more than a minute off 10 kilometers of cycling, whereas slower metabolizers got no benefit, or caffeine actually slows them down, adding 2 minutes to their cycling time, depending on which kind of genes they have that codes the enzymes that breaks it down. But for most people, in most situations, we are more similar than different. While there's undoubtedly a specific minority of individuals who clearly require a more personalized approach to nutrition, there is presently insufficient rationale for truly personalized nutrition for the majority of people. Yet there's an astonishing number of direct-to-consumer genetic testing companies that have proliferated offering personalized nutrition advice. For example, supplement-hawking companies claiming to help consumers optimize micronutrient status on the basis of a handful of genetic variants. But the majority of these variants explain just a few % of the difference in levels between individuals. Personalized nutrition is part of a broader push towards personalized medicine, also known as precision medicine, given the massive cultural allure of personal control over prevention, diagnosis, and treatment of disease, stimulating demand and prompting intense commercialization. But unlike monogenetic diseases, which are rare genetic diseases caused by a single malfunctioning gene like hemophilia or sickle cell anemia, most diseases are caused by a complex interaction between multiple genes with environmental factors, which pose a major challenge for the realization of personalized medicine. Take something like adult stature, for example. We've found at least 40 locations on our chromosomes that have been associated with human height, which is strongly inherited. The genes from your parents account for about 80% of the difference in height between people. Yet all those dozens of genes we found explain only about 5% of height variation between people. Researchers find those genetic links by using what are called genome-wide association studies, where you scan through all the chromosomes and look for statistical associations between diseases and any particular stretches of DNA. OK, that's interesting, but what companies marketing genetic susceptibility tests are doing is reinterpreting these data as if they were predictive of individual risks. But all you're really getting are modest genetic associations with a slight increase in the risk of disease, and with little predictive value when compared to more significant contributions of things we already know, like lifestyle behaviors. Currently, the practice of utilizing the DNA of an individual to predict disease has been judged to provide little or no useful information. For example, let's say your genetic analysis says you're at slightly greater risk for some grave condition compared to others in your ancestral group. This person was given advice to exercise, keep their weight down, not drink too much alcohol, and eat fruits, vegetables, and whole grains. OK, solid advice, but this is how we should live regardless of our genetic risk. And we all know, or should know, these simple bedrock strategies to reduce the risk of common chronic diseases in general. The problem, of course, is that very few individuals live that way. Actually, to be more precise, almost nobody lives that way. That's not just hyperbole. Nationwide surveys show that nearly the entire U.S. population consumes a diet that is not on par with even the wimpy dietary guidelines recommendations. In other words, almost no one in the United States is eating a healthy diet. Studies like that remind us that, from the perspective of public health, worrying about personalizing our preventive strategies based on genetic risk information borders on the absurd. In a review updating the evidence on human exposure and toxicity of pesticides, the body of evidence linking pesticide exposure and cancer is said to be so huge that the role of pesticides in cancer development can no longer be doubted. But most of the evidence that shows DNA damage from pesticides is from occupational exposure among farmers and workers in the fields, the pesticide industry itself, or those living in high-spray areas. There is evidence linking non-occupational exposure to pesticides to DNA damage, in this case single and double-stranded DNA fragmentation in sperm of men with higher levels of pesticides flowing through their bodies. But that was in China, where the average pesticide concentration are as much as 4 times higher than in some other parts of the world. Another way pesticides could potentially facilitate tumor growth is through adverse effects on anti-cancer immunity. NK cells, natural killer cells, are our body's first line of white blood cell defense against cancer cells and virus-infected cells, and pesticides have been shown to induce harmful effects on these defender cells, reducing their ability to kill off tumor cells. For example, if you put a bunch of natural killer cells in a petri dish, along with human leukemia cells without any pesticide, your natural killer cells can clean house and wipe out more than half of the cancer. But if you drip a tiny bit of pesticide on, your NK cells are so disabled that the cancer wins the day. OK, but how much pesticide are we talking? The researchers used the maximum level found in those actively spraying pesticides. Most of us, however, are privileged enough not to be forced into such a job. So what about looking at just the residual pesticides left on conventional produce? Is choosing organic for cancer prevention worth the investment? In the United States, more than 90% of the population has detectable pesticides in their urine and blood, regardless of where they work or live, and we know it's from the food we eat because crossover trials where people are switched between consuming conventionally grown and organic foods show you can turn on and off urinary concentrations of pesticide metabolites like a light switch. But that doesn't necessarily mean the pesticides are harming you. The health consequences of consuming pesticide residues from conventionally grown foods remain unknown, but a recent study did find that those who self-reported the highest frequency of organic food consumption had about a 25% lower risk of getting cancer. And here it is, the first of its kind to evaluate the association between frequency of organic food consumption and cancer risk, controlling for a wide array of other factors. Doesn't it matter that organic consumers are younger? The researchers controlled for that, and still found significantly lower cancer risk. OK, but maybe organic consumers get less cancer because they're more affluent, or more highly educated, or skinnier, or exercise more, or eat less meat, or smoke less. Nope, they controlled for all that, and still found significantly lower cancer risk in organic consumers. Maybe their diets were different in other ways, though, more fruits and vegetables overall, or less junk food? Nope, they still found significantly lower cancer risk. They concluded, our results indicate that higher organic food consumption is indeed associated with a reduction in the risk of overall cancer. This is the most sophisticated study of its type to date, but there was an earlier study that was even bigger, and little evidence was found for a decrease in the incidence of all cancers, except for perhaps one kind of blood cancer, non-Hodgkin's lymphoma. Here are the data. No difference in cancer overall between those who never choose organic or those who usually or always do, with the only significant findings a lower risk of non-Hodgkin lymphoma and an increased risk of breast cancer. Is it possible that women who choose organic food are more conscientious about getting screened for breast cancer, and that explains the higher diagnosis rate? We really don't know. Of course, what we care about the most is not just cancer, but so-called all-cause mortality, the risk of dying prematurely, period. And higher blood levels of a pesticide known as beta-hexachlorocyclohexane are associated with living a significantly shorter life. How do we cut down on our levels? Well, there was a study done way back when that found that the breast milk of a vegetarian mother was found to have less beta-hexachlorocyclohexane than the milk of her sister, who was also breastfeeding at the time, but included meat in her diet. The vegetarian sister apparently had levels of that pesticide that were lower by about a third compared with her omnivorous sibling. No surprise, since this class of chlorinated pesticides are fat-soluble, so they're found most frequently in foods of animal origin. A more recent study failed to look at beta-hexachlorocyclohexane, but they did find that chlorinated PCBs were associated with increased mortality risk, and again, the toxins were found in the same kinds of food, dairy products, eggs, and animal fats. So no surprise the blood of those eating vegan was found to be significantly less polluted than omnivores, regarding a whole series of PCBs, including those found in the study to be associated with increased mortality. But the vegans did not have lower levels of beta-hexachlorocyclohexane. The bottom line is that if you're worried about the adverse health effects of pesticides and pesticide-type compounds, you may want to lower your intake of animal products. But when it comes to fruits and vegetables, the benefits of consuming conventionally grown produce are likely to outweigh any possible risk from pesticide exposure. So concerns over pesticide risk should not discourage us from stuffing our faces with as many fruits and vegetables as possible. That would give us a huge health benefit, whereas the potential lifelong damage of any pesticides on those same fruits and veggies has been estimated to only cut a few minutes off a person's life on average, which is nothing compared to the nutritional benefits of eating more fruits and vegetables. The vast majority of cancer research is devoted to finding cures rather than finding new ways to prevent disease, and the results of these skewed priorities are plain to see. 2021 is the 50th anniversary of Nixon's declaration of war on cancer, and the death tolls from the most common forms of cancer in the United States have continued unabated. We've been looking at the very nature of cancer in the wrong way. Breast cancer doesn't begin when a lump is first detected. All the common cancers, like lung, colorectal, breast, and prostate, which accounts for the majority of deaths, have a long latency period, often 20 years or more. So it's not like you were healthy and then one day you got cancer. You haven't been healthy. You've had cancer growing in you for decades. Indeed, there's a bizarre misperception that people are healthy until they have actual symptoms of invasive cancer. But the barn in which hay is smoldering before it bursts into flames is not a safe place. So what does this professor of pharmacology recommend? Drugs, of course. Chemoprevention, putting people on drugs to prevent cancer. Hey, the pharmaceutical industry spends huge amounts of money to promote chemoprevention of heart disease and strokes with statins and blood thinners, so why shouldn't people take drugs every day for the rest of their lives to protect against cancer? There has to be a better way. What about using diet and nutrition to prevent and treat cancer? OK, but what kind of cancer? There are more than 200 types of cancer. But they all share the same hallmarks. In a series of papers cited more than 40,000 times in the biomedical literature, 10 hallmarks of cancer have been identified. Increased sensitivity to growth factors, evading your body's tumor suppressors, dodging your immune system, being able to grow forever, tumor-promoting inflammation, the ability to invade and spread and hook up its own blood supply, the accumulation of DNA mutations, disarming the self-destruct mechanisms in place, and hijacking the cell's metabolism. And yes, of course, there are classes of drugs to try to counter each one, chemotherapy agents designed to target each piece of the cancer puzzle. Now, ideally, there'd be drugs able to target multiple hallmarks at the same time, but that's not how drugs tend to work. And this is one of the major reasons why, in the context of cancer research, there are so many proponents of investigating plant foods, as they can deliver a cocktail of bioactive compounds that may target most, if not all, of the hallmarks of cancer. Here's a sampling of compounds found in fruits and vegetables, such as berries, greens, and broccoli, shown to be able to target each of the 10 hallmarks of cancer, at least in a petri dish. Moreover, they fit the characteristics of an ideal chemopreventive agent. If you were to design the perfect candidate, you'd want them to be selective for cancerous or precancerous cells while leaving normal cells alone, be side-effect-free, target most types of cancer, be able to be consumed as part of a daily diet, be conveniently available almost everywhere, and be relatively inexpensive to boot. And plants have all these. So no wonder those eating more plant-based tend to have lower cancer rates. However, it should be understood that we're not talking about taking supplements containing extracts or purified phytochemicals, but rather eating whole plant foods themselves, more of a food system-based approach to targeting the hallmarks of cancer. Foods contain many thousands of substances that lead to vast numbers of possible interactions, yet much of nutritional science has long been directed towards the impact of single dietary components. Yes, this kind of reductionist approach can reveal the role of individual nutrients or foods in the development of disease, but let's think about what the optimal research strategy would be to study the effects of bioactive natural plant compounds on disease prevention. Instead of using isolated phytochemicals in the management of cancer, how about using whole foods? Because sometimes the whole can be greater than the sum of its parts, a concept known as food synergy. Check out this study. The simultaneous inhibition of a series of cancer stages in breast cancer cells using a phytochemical super cocktail. 2 breast cancer cell lines were treated with 6 different plant compounds individually, and then all together at the level you might find in your bloodstream after eating foods like broccoli, grapes, soybeans, and turmeric. And while the compounds were ineffective individually, in combination, they significantly suppressed breast cancer cell proliferation by more than 80%. Inhibited cancer cell migration and invasion, stopped the cancer cells in their tracks, and eventually killed them all off. The plant compounds did all of this without having any deleterious effects on the normal non-cancerous cells used as control. No wonder the foundation of cancer prevention, based on an update of the most extensive report on diet and cancer ever published, is not pills, but plants. Cut down on alcohol, soda, meat, and processed junk, and center your diet around whole grains, vegetables, fruits, and beans. In a landmark case that made it all the way up to the U.S. Court of Appeals before being denied review by the Supreme Court, POM Wonderful, the pomegranate juice company, versus the Federal Trade Commission. A panel of judges concluded that many of POM's ads made misleading or false claims, touting medical studies ostensibly showing that pomegranate products could help treat various ailments, including heart disease, prostate cancer, and erectile dysfunction. And the First Amendment does not protect deceptive and misleading advertisements. Striking a blow to its billionaire owners, the court ruled that at least one randomized clinical trial could be required to substantiate any claims of treating or preventing disease. If you look at the medical literature, the benefits of pomegranates in general, you'll see reviews like this, with diagrams like this, on the medicinal effects of pomegranate. But if you dig a little deeper, you see this is based on studies like this: anti-obesity effects of pomegranate leaf extract in a mouse model. First of all, who eats pomegranate leaves? And second of all, who's a mouse? And if you do have a fat pet mouse, maybe just feed them less lard. Does pomegranate consumption affect weight in humans? If you look at all the randomized controlled clinical trials, meaning human trials, pomegranates have no significant effect on body weight, BMI, belly fat, or even body fat percentage in those randomized to pomegranate product consumption. Well, what about for the prevention and treatment of cardiovascular diseases? Researchers reviewed 25 clinical trials looking at cholesterol, blood pressure, artery function, atherosclerotic plaque formation, and platelet function, and even in the best studies, they did not find significant indications of benefit. Here's a study on pomegranate juice and erectile dysfunction. It was funded by the POM company, and yet it failed as well. No benefit for diabetes markers, and no benefit for chronic obstructive pulmonary diseases like emphysema. They were banking on the antioxidant activity of pomegranate juice to help, but that's antioxidant activity in vitro, meaning in a test tube or petri dish. To my surprise, a meta-analysis of data from 11 randomized controlled trials did not support convincing evidence of pomegranate intake having a significant increasing effect on total antioxidant capacity of your bloodstream, because some of the most potent antioxidants don't even seem to be absorbed into the human body. No wonder pomegranate supplementation didn't seem to affect oxidative stress in tissue samples taken from prostate cancer patients. But of course, what we care about is whether it affects the cancer itself. The strongest evidence for the anti-cancer activity of pomegranates is said to come from studies on prostate cancer. Unfortunately, early promising results were not confirmed when they were actually put to the test. For example, daily pomegranate intake was found in a randomized controlled trial to have no impact on PSA levels, a marker of tumor progression. And indeed, a randomized, double-blind, placebo-controlled trial found essentially no difference when it came to prostate cancer disease progression. They were banking on the anti-inflammatory activity of pomegranate juice to help, but again, that had been demonstrated in vitro. In people, a meta-analysis based on 5 randomized controlled trials published in 2016, conclude that pomegranate juice did not have a significant effect on C-reactive protein levels, a key marker of inflammation. If you look at the forest plot, though, you'll see all 5 trials tended towards lower C-reactive protein levels, such that the data combined almost reached statistical significance, and indeed, an updated meta-analysis published in 2020, based on 7 studies, did indeed get tipped over into significance, and found a significant drop in 2 other inflammatory markers as well. OK. Well, maybe pomegranate juice could help in the control of inflammatory diseases after all. But you don't know until you put it to the test. Osteoarthritis involves the degeneration of the cushioning cartilage within joints, particularly the knees. If you take some human osteoarthritic cartilage samples and you drip on a pomegranate extract, you can show cartilage protective effects. Here's how much cartilage disintegration was happening at baseline. Add some inflammation, and cartilage breakdown triples, but then add more and more of this pomegranate extract, and you can calm things down. But again, that's in a petri dish. How do we know that when we eat pomegranates, the active components actually get into our bloodstream so they can find their way into our joints? Cartilage-protecting components were found to be bioavailable, well, at least in rabbits, raising the possibility that pomegranates could be a safe and non-toxic treatment with no side effects, as opposed to the drugs currently in use. But is it effective? Clinical trials are in progress, and so many questions will be answered right now. The first and only clinical trial to date on pomegranate juice and osteoarthritis, not a placebo-controlled trial, instead randomizing people to pomegranate juice or nothing at all. Those drinking the juice did report less stiffness and impairment of physical function, but not significantly better than just doing nothing. Shoot. But just as I was about to give up on pomegranates, I saw this study. Consumption of a pomegranate extract suppresses joint damage in rheumatoid arthritis. But no, it was just the Palm not-so-wonderful company inducing joint damage in a mouse as a model of rheumatoid arthritis. Come on. What about this open-labeled study, where the patients knew what they were getting? 8 people with active rheumatoid arthritis took some pomegranate extract every day, and the 6 who stuck with it reported fewer tender joints. But as we learned from the osteoarthritis study, if you don't have a control group, you have no sense at all what role, if any, the treatment actually plays. So finally, we come to this. A randomized, double-blind, placebo-controlled trial. It's about time. Half of the subjects unknowingly got some pomegranate extracts. The other half unknowingly got the equivalent of a sugar pill, and significant improvement in the number of swollen joints, tender joints, pain intensity, a disease activity score, a health assessment questionnaire, and morning stiffness compared to placebo. So if you have rheumatoid arthritis, I would indeed recommend you start eating pomegranates. Why not just pop pomegranate pills? After all, it was a pomegranate extract that alleviated disease activity. Well, one good reason to stick to the fruit is that when 19 pomegranate supplements were actually tested in a laboratory, most didn't actually appear to have any pomegranate in them at all. Only 6 out of 19 appeared to be authentic. Excessive inflammation may play a role in a number of leading causes of death and disability, including type 2 diabetes, obesity, heart disease. But what are the stimuli that jumpstart the deleterious inflammatory cascade? You typically hear about the pro-inflammatory nature of a chronic high-fat diet, but the inflammatory effect may not be limited to chronic intake. It may be evident after the consumption of a single meal. Within hours after eating an unhealthy meal, inflammatory markers like IL-6, interleukin-6, can skyrocket, doubling within 6 hours. The majority of studies show an increase in IL-6 after the consumption of a high-fat meal. But the meals they tested weren't just filled with meat, eggs, dairy, and oil, but also junky refined carbs like white flour and added sugar. Yes, give people essentially straight butterfat and no carbs, and you can still get a spike in inflammation within hours, proving the added fat itself is pro-inflammatory. But give people straight sugar water without any fat, and you can get the same thing, proving the added sugar is pro-inflammatory too. Why should we be concerned with the inflammatory responses after unhealthy meal ingestion? Because substantial research points to the notion that persistent low-grade inflammation is an underlying factor in several high-mortality chronic diseases, and that diet can contribute to or attenuate that inflammation. You'll note in this graph that IL-6 levels jumped up to about 3 picograms per milliliter. You start regularly getting up to levels of about 3, and that's associated with twice the risk of death. And that increased risk was found across the board, compiling 8 other similar studies, likely because it's linked to an increased risk of heart disease, the #1 killer of men and women, even about as strongly as some other major established risk factors like high cholesterol. Now, not all high-fat foods cause inflammation. More than a dozen studies combined show that whole plant foods such as nuts do not increase inflammatory markers, even eating up to handfuls of nuts a day. In fact, spread half an avocado on a beef burger, and you may be able to blunt some of the inflammation caused by the meat, even lean meat. There are reviews purporting to show a drop in inflammatory markers after eating wild game, which is about as lean a meat as you can get, but that's only compared to store-bought meat. Give people some really fatty meat, and their IL-6 shoots up, as does their tumor necrosis factor and C-reactive protein, inflammatory, within hours of it going into your mouth. But what if you instead eat a kangaroo steak, extremely low fat on the order of elk or moose? What you get is inflammatory, again within hours of it going into your mouth. Now, certainly less inflammatory than conventional meat you might get at the store, but pro-inflammatory nonetheless, increasing markers of inflammation within mere hours. Intervention studies to enhance healthy aging need appropriate outcome measures, such as blood-borne biomarkers, which are easily attainable, cost-effective, and widely accepted. We need blood-borne biomarkers of mortality risk. For example, having higher levels of C-reactive protein in your blood may increase your risk of dying prematurely by 42%. C-reactive protein is the most widely used inflammatory biomarkers for predicting mortality, but those with the highest levels of IL-6, interleukin-6, another marker of inflammation, may increase premature death risk 49%. What can we do to bring it down? In my last video, I talked about foods we eat that can contribute to inflammation, like meat and sugar, versus foods like nuts that don't. But what about anti-inflammatory foods that actually attenuate that inflammation? Let's see what happens when you add blueberries to a high-fat meal with a high glycemic load. White potatoes, white bread, ham, cheese, butter, and more cheese, with or without a single cup of blueberries. Add blueberries, and get a significant drop in IL-6 from that meal. What about raspberries? Feed people eggs, butter, white potatoes, white flour biscuits, and sausage, with or without 2 cups of frozen raspberries blended with water into a smoothie, compared to giving people the same amount of calories and carbs in banana form, and bananas were no match for the meat, eggs, dairy, and crappy carbs that resulted in a tripling of IL-6 levels within 4 hours. But instead, drink those 2 cups of raspberries, and your body's able to hold the line. Why did raspberries work, whereas bananas didn't? Maybe it's the antioxidants? Well, antioxidant supplements failed miserably. No benefit from antioxidant vitamins and minerals like vitamin C and E, beta-carotene, or selenium. Maybe it's those special antioxidant pigments, the anthocyanins, that give berries those bright red, blue, and purple colors. And indeed, that's what dozens of randomized controlled trials have demonstrated, whereas a half-dozen studies combined show pomegranates, a fruit packed with anthocyanin pigments, can bring down inflammation over time. What about adding spices to meals as an approach to cool down inflammation? Supplementation with grape and turmeric extracts did not affect the inflammatory response to a milkshake, but give people actual turmeric, 1 teaspoon a day of the whole spice, and you can get a significant drop in IL-6 levels, but not when you just give people purified curcumin supplements. Garlic powder reduced IL-6 levels as well, starting at about a half a teaspoon a day, and ginger powder, just ground ginger, show the same thing, with doses ranging from half a teaspoon to 1½ teaspoons. Of course, another way to mediate the inflammation caused by a sausage and egg McMuffin is to not eat it in the first place. What about just eating a plant-based diet? To my surprise, the drop in IL-6 did not reach statistical significance. Whenever a dietary intervention doesn't have the result you expect, you always have to ask, well, what was the diet they exactly ate? The study mostly looked at the Mediterranean diet, which certainly has more plants, but maybe the diets didn't go far enough. To figure that out, we can turn to Dr. Turner McGreevy's famous New Diets study, where people either continued to eat their regular, fully omnivorous diets, or were randomized to eat a vegan diet, a vegetarian diet, a pesco-vegetarian diet, or a semi-vegetarian diet that, for example, limited red meat. So whereas the vegan might eat red beans and brown rice with chopped tomatoes and roasted peppers for dinner, the ovo-lacto-vegetarians might add some cheese. The pesco-vegetarian might add shrimp, and the semi-vegetarian might have some turkey sausage. What happened within 2 months to their dietary inflammatory index scores? The dietary inflammatory index is a measure of how inflammatory your diet is. Negative scores mean your overall diet is anti-inflammatory, and the lower the better, whereas positive scores mean your diet is, on balance, pro-inflammatory. And that's exactly where they all started out. No surprise, as they were eating regular diets, and our nation is awash with inflammation-related disease. But ask people to switch to strictly plant-based nutrition, and their diet flips to become an anti-inflammatory diet. And that was the case, even if they just cut out meat, or just all meat except fish, but have them instead switch mostly to poultry, or simply limit their meat intake, and their diet remains inflammatory. Now, not all plant foods are anti-inflammatory. If all you do is boost your intake of less healthy plant foods like juice, white bread, white potato, soda, and cake, you can end up even more inflamed. But if you eat a really clean diet of whole plant foods, not only do you get a significant reductions in Lp(a), which we didn't even think was possible with diet, as well as drops in LDL cholesterol, of course, and even the most dangerous form of LDL cholesterol, but nearly across the board, you also get a drop in inflammatory markers. We're talking a 30% drop in C-reactive protein, a 20% drop in IL-6. So maybe previous studies utilizing plant-centered diets were unsuccessful because they weren't plant-based enough, with animal products still being substantially consumed. The total elimination of animal products and processed foods may therefore be a more prudent dietary strategy to combat inflammation. The main purpose of frying is to produce foods with good consumer acceptability. However, not all acceptable foods are safe. Food chemists have been keenly interested in the newly discovered toxic compounds produced by frying. We've been refining vegetable oils for more than a century, but only recently have we discovered that this can produce concerning compounds such as 3-MCPD, and even worse, glycidol. I talked previously about 3-MCPD. It's considered a non-genotoxic carcinogen with a tolerable daily intake, whereas glycidol is a known genotoxic carcinogen, meaning it can cause cancer by directly damaging our DNA. If a compound is not directly DNA damaging, it's assumed that it acts through a mechanism that exhibits a threshold. A so-called no-effect level may exist, a level below which the compound may not be harmful. But if a compound does damage DNA, historically a non-threshold mechanism is assumed, and no safe level of intake can be derived, because it may only take a single DNA mutation to start the march towards cancer. So such substances are not permitted to be added intentionally to foods. For so-called unavoidable contaminants, the ALARA approach is applied, meaning that the level should be as low as reasonably achievable, or as low as reasonably practical. Since that's what glycidol appears to be, we should try to avoid it as much as possible. An excess lifetime cancer risk of 1 in 100,000 is often used as a figure for acceptable risk in a population. Based on lab animal data, this might be exceeded if someone weighing about 150 pounds consumed less than a microgram a day. Thanks to the use of refined oils in so many food products, though, the average glycidol exposure may be more than 50 micrograms, and in children the level of intake may exceed acceptable cancer risk by 200-fold. So, do people who eat more fried food get more cancer? There is said to be strong evidence that there may be a high risk of developing chronic disease among frequent consumers of fried foods, but that's talking largely about cardiovascular health. For example, in a study of more than 100,000 women, frequent consumption of fried foods, especially fried chicken and fried fish, were associated with a higher risk of all-cause mortality, meaning such consumers lived, on average, significantly shorter lives. but that was largely due to cardiovascular mortality, whereas fried food consumption was not generally associated with dying from cancer. In men, however, a larger intake of fried food was associated with a 35% increased risk of prostate cancer. Therefore, a suggestion may be put forward that subjects at increased risk of prostate cancer should, as a precaution, limit their consumption of fried foods. These refined oils are also used in infant formulas, which presents a problem for babies who aren't breastfed. The German Federal Institute for Risk Assessment has come to the conclusion that infants who are fed exclusively industrial-prepared infant milk formula would take in harmful levels of glycidol, and they have comparable levels of glycidol contamination in U.S. formula as they do over in Europe. Yet another reason that breast is absolutely best. Meanwhile, there are calls on the manufacturers of these products to do everything they can to reduce levels as far as possible. But evidently the industry has yet to find a way to refine vegetable oils without creating these kind of byproducts, while at the same time maintaining the quality. It is therefore concluded that there are no easy solutions to this problem. But I disagree. We can choose to avoid the use of oils in fried foods. The act of defecation involves a very private sphere, and is the object of cultural taboos, so much so that it's rarely thought of even by physicians. But it should be. Constipation accounts for 3 million annual visits to doctors in the United States and 800,000 emergency room visits. Depending on how you define it, up to 80% of the population may be suffering. Even people who don't think they're constipated may very well be clinically constipated. A quarter of their so-called healthy subjects reported experiencing incomplete emptying, and approximately half indicated increased straining. In fact, more than half had found blood on their toilet paper within the past year. In severe cases, the blood pressure spike associated with straining at stool can even trigger a heart attack or stroke. There are drugs for it, there are always drugs, resulting in side effects like headache, nausea, diarrhea, and abdominal pain, leaving most patients unsatisfied. So why not instead just try to treat the cause? Common causes of chronic constipation include lack of adequate whole plant foods or insufficient water intake, so making changes in the patient's diet and lifestyle is the preferred method for relieving constipation. Such non-pharmacological clinical effective interventions include engaging in physical activity for about 30 minutes a day. A systematic review and meta-analysis found aerobic exercise interventions help, starting at about 140 minutes a week, and then, of course, a diet centered around whole plant foods, which are the only naturally concentrated sources of fiber. Any plants in particular? If you give elderly women with severe constipation about a dozen prunes a day, they experienced significant improvement within the first week. The control group in the study wasn't told to do anything, though, and anytime you have one group doing something and the other doing nothing, you can't discount the placebo effect. And the placebo response for constipation trials can range up to 44%, meaning up to nearly half of the people given a sugar pill claim to experience an improvement. So that's why we need studies like this. Subjects were randomized to about 8 prunes a day, plus a large glass of water, 12 prunes in water, or just the water alone. So even the control group got an intervention they were told might help with constipation. Previous studies mostly assigned 10 prunes or so a day, so the researchers wanted to see if more was better or less was sufficient. And they found a significant improvement in stool bulk on the prunes, and a significant increase in bowel movement frequency, though no real difference between 8 and 12, so 8 a day seems sufficient. Prunes even appear superior to psyllium, sold as Metamucil, beating it out in terms of improved stool frequency and consistency. We used to think it was just all the fiber in prunes that was helping, but prune juice evidently works too, which, like most juices, has had the fiber removed. Other potential active components include a natural sugar alcohol known as sorbitol that's used in some sugar-free gum. Once you eat more than a dozen or so large prunes a day, however, the dose of sorbitol could start reaching laxative levels in susceptible individuals, so be careful. If you don't have constipation, should you avoid prunes? That's been put to the test, and most people should be able to eat a dozen or so a day without any issues. In fact, it's interesting to note that prunes have been traditionally used as both a laxative and an anti-diarrheal remedy. What about dried figs, one of the few medicinal plants mentioned explicitly in the Bible? Researchers took patients with a type of irritable bowel syndrome characterized by constipation and randomized them to 1 fig with breakfast and 1 fig with lunch, each with a glass of water. And there was significant improvement in frequency of defecation and a significant drop in the frequency of hard stools compared to control. But what was the control? The control group was just asked to continue their normal diet. In other words, to do nothing special. The placebo response for irritable bowel is infamous. Give people with IBS a fake sugar pill, and sometimes 72% say they magically feel better. That's why we need this kind of study, a randomized, double-blind, placebo-controlled trial. Researchers made a gross-sounding fig paste placebo that supposedly had the same taste, smell, and appearance as the real deal. Those who got the real figs, about 6 a day, seemed to improve colon transit time, stool consistency, and abdominal discomfort compared to the placebo. Researchers measured transit time by having people swallow little beads that would show up on X-rays so they could track the progress through the digestive system. They found that those eating the real figs sped up their gut movement by a full 24 hours. Defecation frequency per week didn't beat out placebo, though. In fact, they tested so many different outcomes. Even the stool consistency and tummy discomfort results may have been statistical flukes. So it looks like prunes would be the better treatment choice. The trouble for white potatoes began in 2006, when the Harvard Nurses' Health Study, which had followed the diets and diseases of tens of thousands of women for 20 years, found that greater potato intake was associated with a greater likelihood of getting type 2 diabetes. OK, but wait. Of the 100 or so pounds of potatoes Americans eat every year, most are in deep-fried form of potato chips and French fries. What happened when they looked specifically at mashed or baked potatoes? They found the same link with diabetes. OK, but what might potato eaters eat more of? I'll give you a hint by rephrasing that as, what might meat and potatoes people eat more of? Indeed, people who ate more potatoes ate more meat, and we know that animal protein on its own is associated with increased diabetes risk. But the researchers tried to statistically adjust for that, and still found increased risk with potatoes. Well, what do people put on baked and mashed potatoes? Butter, sour cream? Again, the researchers tried to adjust for other dietary factors like these, as well as effectively looking at the ratio between plant and animal fats, and whether potato eaters drank more soda or maybe skimped on other vegetables, and there still seemed to be this potato diabetes association. OK, but that was just one study. By 2015, Harvard researchers had also looked into other cohorts, including the all-male health professionals follow-up study to complement the all-female nurses studies, and they continued to find a small increased diabetes risk associated with baked, boiled, or mashed potatoes, though French fries do indeed appear nearly 5 times worse. The authors concluded that potatoes are considered to be a healthy vegetable in dietary guidelines. However, the current findings cast serious doubts on that classification. Walt Willett, the chair of Harvard's nutrition department at the time, went a step further, suggesting potatoes should be siloed up there with candy. A meta-analysis of potato consumption and risk of type 2 diabetes, published in 2018, combined all 6 of the prospective studies that have been done to date, and they found about a 20% increase in diabetes risk associated with each serving of potatoes a day, concluding long-term high consumption of potato may be strongly associated with increased risk of diabetes. But again, the great majority of this potato consumption was fried, and we know there are all sorts of nasty things like advanced glycation end products and deep-fried foods, and the researchers were unable to assess French fries versus non-fried potatoes. Even just 3 servings of fries a week is associated with nearly 20% greater risk of type 2 diabetes, whereas there was only a tiny associated risk with potatoes in general, and that included the fries mixed in. The world's largest manufacturer of frozen French fries took issue with this conclusion, laying claim to 1 in 3 fries eaten on planet Earth to the tune of billions of dollars. They have the money to fund reviews like this one to cast doubt on the science, but they do have an actual point. Observational studies can never prove cause and effect, and maybe potato consumption, even baked potato consumption, may just be a marker for an unhealthy diet in general. As much as researchers try to adjust for these other factors, as the Journal of the Potato Association of America is quick to remind us, it's not possible to completely separate the effects of potatoes and French fries from the effects of the overall crappy standard American diet. If only there was a country where potato consumption was associated with a healthy diet. If potato consumption was still associated with diabetes there, then that would be concerning. But here we go. A seventh study, but this time out of Iran, where not only is most of their potato consumption from boiled potatoes, but those who eat potatoes had the healthiest diets, ate the most whole plant foods, vegetables, whole grains, and beans. And although the researchers tried to tease out those other dietary factors, those eating the most boiled potatoes had only half the odds of developing diabetes. This supports the notion that it may be hard to completely separate out just the potato. The bottom line, this systematic review concluded, is that we really don't have convincing evidence to date that the intake of potatoes in general is linked to type 2 diabetes, but we should still probably hold the fries. Potato intake and the incidence of hypertension. Harvard researchers followed the diets and diseases of more than 100,000 men and women for decades, and found that those who ate potatoes on most days, even just baked, boiled, or mashed, not just French fries and potato chips, appeared to be at higher risk of developing high blood pressure. OK, but what do people put on potatoes? Salt, not to mention butter, so maybe the potatoes are just innocent bystanders. Maybe, but the researchers made attempts to tease out the effects of salt and saturated fat, and there still seemed to be a link between potato consumption and high blood pressure. Maybe potato eaters are just meat and potatoes people? After all, these same Harvard researchers had found that meat, including poultry, alone appeared to be associated with an increased risk of hypertension, and same with even a moderate amount of canned tuna. So in the potato study, they were careful to try to factor out any effects from the consumption of all types of animal flesh, yet they still found increased potato risk and got concerned that the association of potato intake with hypertension could be a critical public health problem. We'd assumed potatoes might actually decrease high blood pressure, given their high potassium content, but they found evidence of the opposite effect. Two similar studies performed in Mediterranean Europe did not find any association between potato consumption and high blood pressure, though. Perhaps this is because they don't smother their potatoes in butter and sour cream in that neck of the woods, and instead eat potatoes with other vegetables. Now, the Harvard folks tried to control for the bad, salty, and fatty dietary components associated with eating potatoes in the West, just like these researchers tried to factor out all the extra vegetables, but you can't control for everything. The primary reason we care about blood pressure is because we care about the consequences. In two studies done in Sweden, where they primarily eat their potatoes boiled, no evidence was found that potato consumption was associated with the risk of major cardiovascular disease, and no relationship was found between potato consumption and risk of premature death found in southern Italy either. In the U.S., however, potato consumption was associated with increased mortality, a whopping 65% increased risk of dying from heart disease, 26% increased fatal stroke risk, a 50% increased risk of dying from cancer, and increased risk of dying from all causes put together. This all disappeared after adjustment for confounding factors. In other words, it wasn't the potatoes at all. Potato eaters must just smoke or drink more, or eat more saturated fat or something. Once you control for all these other factors, the link between potatoes and death disappears. This was confirmed in the NIH AARP study, the largest such study of diet and health in human history. If you just separate out the potatoes, researchers find that they are not associated with increased risk of death, with the possible exception of French fries, which are associated with increased risk of dying from cancer. Put all the studies together, 20 in all, and no significant association has been found between potato consumption and mortality, though again, fried potatoes may be the exception. Even just twice a week, fries may double one's risk of dying prematurely, independently of other factors, but the consumption of unfried potatoes seemed to be neutral. It's funny. I've done a bunch of videos on how all plant foods are not created equal, talking about healthy versus unhealthy plant-based diets. To this end, researchers created not just an overall plant-based diet index, just scoring plant versus animal foods, but also a healthy plant-based diet index and an unhealthy plant-based diet index. The healthy index puts a greater emphasis on whole plant foods, whereas the unhealthy index scores how much low-quality plant foods you're eating, grouping potatoes along with soda and cake and Wonder Bread. Then when you run the numbers, the more plant-based you eat, the longer you live, the lower your risk of cardiovascular disease. In other words, more plant foods and less animal foods are associated with a significantly lower risk of dying prematurely. This benefit was limited, though, to those eating the healthier plant food diets, But they were surprised that those eating all that processed plant-based crap didn't live significantly shorter lives. Now, maybe that's just because they were eating fewer animal products, and that's really the primary determinant of lifespan here. Or maybe the lack of an association between less healthy plant-based diets and mortality outcomes is because potatoes were kind of coming to the rescue. And indeed, higher intake of potatoes did appear protective, so given these conflicting findings, future studies may consider just resigning fried potatoes to the unhealthy list. Now, in terms of mortality, fried potatoes may not be as bad as fried meat, fried chicken, fried fish, but that's not really saying much. The French fry death data gave industry trade group Potatoes USA a bit of a chip on their shoulder, reminding readers that observational studies can only prove correlation, not causation, to which the authors replied, "Our data add to the pressing public health calls to limit fried potato consumption. French fries may be so bad for you that it wouldn't be ethical to do an interventional study and randomize people to eat them." If you systematically pull together all the best studies on potato consumption and chronic disease risk, an association is found for the risk of type 2 diabetes and hypertension. Yeah, but that was for French fries. Consumption of boiled, baked, or mashed potatoes was not associated with the risk of high blood pressure, but there was still a pesky link with diabetes. Overall, potato consumption is not related to the risk for many chronic diseases, but boiled potatoes could potentially pose a small increase in risk for diabetes. And that's one of the reasons some question whether they should be counted as vegetables when you're trying to reach your recommended daily servings of fruits and vegetables. If you look at other whole plant foods, nuts, vegetables, fruits, and legumes, which are beans, split peas, chickpeas, and lentils, they're associated with living a longer life, significantly less risk of dying from cancer, dying from cardiovascular diseases like heart attacks, and 25% less chance of dying prematurely from all causes put together, but no such protection is gained from potatoes for cancer, heart disease, or overall mortality. So the fact that potatoes don't seem to affect mortality can be seen as a downside. Now, it's not like meat, which may actually actively shorten your life, but there may be an opportunity cost eating white potatoes, since every bite of potato is a lost opportunity to put something even healthier in your mouth, something that may actively make you live longer. So potatoes are kind of a double-edged sword. The reason that potato consumption may just have a neutral impact on mortality risk is that all the fiber, vitamin C, and potassium in white potatoes might be counterbalanced by the detrimental effects of their high glycemic index. Not only are high glycemic impact diets robustly associated with developing type 2 diabetes, but current evidence suggests this relationship is cause and effect. Now, a front group for the potato industry, called the Alliance for Potato Research and Education, funded a study that found that intake of non-fried potato does not affect blood sugar markers. But that's compared with the likes of Wonder Bread, so that isn't really saying very much. Foods with a glycemic index above 70 are classified as high GI foods, high glycemic index foods, and those lower than 55 are low GI foods. Pure sugar water, for example, is often standardized at 100. White bread and white potatoes are way up there as high glycemic index foods, but when you compare them to an intact grain, like barley groats, also known as pot barley, a super low GI food, you can see how refined grains and potatoes are simply no match. Is there any way we can have our potatoes and eat them too, by somehow lowering their glycemic index? Well, if you boil potatoes and then put them in the fridge to cool, some of the starch crystallizes into a form that can no longer be broken down by the starch-munching enzymes in your gut. However, the amounts of this so-called resistant starch that are formed are relatively small, making it difficult to recommend cold potatoes as a solution. But when put to the test, you actually see a dramatic drop in glycemic index in cold versus hot potatoes. So by consuming potatoes as potato salad, for instance, you can get nearly a 40% lower glycemic impact. The chilling effect might therefore also slow the rate at which the starch is broken down and absorbed. So individuals wishing to minimize dietary glycemic index may be advised to pre-cook potatoes and consume them cold, or reheated. The downside of eating potatoes cold is that they might not be as satiating as eating hot potatoes, But you may get the best of both worlds by cooling them, then reheating them, which is exactly what was done in that famous study I profiled in my book, How Not to Diet. The single most satiating food out of the dozens tested was boiled, then cooled, then reheated potatoes. There's actually an appetite-suppressing protein in potatoes called potato protease inhibitor 2, but the way you prepare your potatoes makes a difference. Both boiled and mashed potatoes are significantly more satiating than French fries. That was for fried French fries, though. What about baked French fries? Folks had a big drop in appetite after eating boiled mashed potatoes compared to white rice or white pasta, which is right where fried French fries were stuck, as well as baked French fries. So though they may be your BFF, they're not very satiating. White potatoes have a high glycemic index, and consumption of high glycemic impact foods may increase the risk of diabetes. Normally after a meal, we'd like our blood sugars to just gently, naturally rise and fall. But with high glycemic foods like potatoes, you get an exaggerated blood sugar spike, which leads your body to overcompensate with insulin, forcing your blood sugars lower than when you started, which results in negative metabolic consequences, such as a rise in triglyceride fats in the blood. However, potatoes are a good source of potassium, vitamin C, and polyphenols, which may counterbalance the glycemic impact. This may explain why potatoes appear to have a neutral effect when it comes to lifespan, unlike other whole plant foods that have been associated with actively living longer. In my last video, I detailed my nip and nuke method, where the act of chilling potatoes can dramatically lower their glycemic index, even if you then reheat them in a microwave. How else might we reduce the glycemic impact of white potatoes? The answer is the same way you make anything better in your nutritional life: add broccoli. The co-consumption of 2 servings of cooked broccoli with your mashed potatoes would certainly do it, immediately cutting the insulin demand by nearly 40%. In contrast, adding chicken breast makes things worse, and adding tuna fish makes things even worse still, nearly doubling the amount of insulin your body has to pump out. But why does plant protein make things better, but animal protein makes things worse? Because decreased consumption of branched-chain amino acids improves metabolic health. I cover this in my book, How Not to Diet, as well as in my video on the topic. Speaking of how not to diet, remember the section on vinegar? Here's the blood sugar and insulin spike someone with prediabetes can get from eating a bagel. If you eat that same bagel with a tablespoon or so of apple cider vinegar diluted in about a quarter cup of water, though, the impact is significantly less. Does it work for potatoes too? Simply chilling potatoes may cut down the blood sugar and insulin spikes, but to get significant drops in both, you just have to add about a tablespoon of vinegar to drop levels by 30 to 40%. That was just plain white distilled vinegar. Is it the vinegar itself, or would any acidy condiment do? In a test tube, lemon juice appeared to have a remarkable starch-blocking effect, but you can't know if it works in people until you put it to the test. And indeed, lemon juice reduces the glycemic responses to bread, and not just by a little, but like 30%. Now, the subjects were drinking a half cup of lemon juice, but that makes it even more remarkable that it helped, because that added an extra half teaspoon of sugar, yet they still had a better blood sugar response. Vinegar is more potent, though. Just 1 to 2 tablespoons a day of vinegar diluted in water can significantly improve both short- and long-term blood sugar control in diabetics, which is why clinicians may want to incorporate vinegar consumption as part of their dietary advice for patients with diabetes. The high glycemic impact of potatoes may increase the risk of type 2 diabetes, perhaps by chronically overstimulating the insulin-producing cells in the pancreas. In my last 2 videos, I explained how you can decrease the glycemic impact of white potatoes by eating them cold, or chilling then reheating them, or adding broccoli, lemon juice, or vinegar. What else can we do? Well, if you remember, I had a video a few years back that showed how the pigments in brightly colored berries can act as starch blockers. So if you're going to eat a high glycemic food, you may be able to moderate its impact by spreading raspberries on your toast, for example, or adding strawberries to your cornflakes, or sprinkling blueberries in your pancakes. No, I'm not saying you have to put blackberries in your baked potato, but given that the natural color compounds in fruits can slow down starch digestion, what about pigmented potatoes. Even just yellow potatoes like Yukon Gold may be preferable to white, but the best may be purple potatoes. Not just purple-skinned potatoes, but purple-fleshed potatoes. If you've never seen purple potatoes, they are remarkable. They have almost a neon blue glow. And not only do they look cool, but purple potatoes cause less of an insulin and blood sugar spike compared to even the yellow-fleshed potatoes, suggesting that switching from yellow or white to purple could have a large potential public health benefit. How do we know it's the pigments themselves that are responsible, rather than other differences between the different potato varieties? Researchers tried adding a control comprised of berries and a potato starch jelly, but that would seem to add even more variables. In a test tube, extracts of purple and red-fleshed potatoes can act as starch blockers, so hey, if you can extract and purify out the purple potato pigments, say that 5 times fast, you could remove any other effects of the different potato varieties by adding the purple pigments to yellow potatoes. And lo and behold, compared to just plain yellow potatoes, you can get a suppression of the blood sugar and insulin spikes. This way you don't get that overshoot reaction, where your blood sugars can actually drop below fasting, like you might get otherwise. Instead, you get the gentler up and down in blood sugars you'd expect from a lower glycemic food. The authors suggest purple potato extracts could be produced and made into supplements or fancy functional foods, but these health-promoting compounds may be more cost-effectively received from consuming purple potatoes themselves. If you were paying attention, you might have caught in the title as it flashed by that the purple potato pigments may also affect inflammation. The Potato Association of America likes to paint potatoes as an anti-inflammatory food, but what they don't tell you is that this benefit may be limited to pigmented potatoes. If you randomize people to eat a small white potato every day for 6 weeks versus a yellow or purple-fleshed potato, the purple potato group achieves significantly lower levels of inflammation compared to the white potato group, measuring both C-reactive protein and interleukin-6. Pigmented potato consumption also alters oxidative stress. Within hours of eating a large purple potato, you get a nice 60% bump in the antioxidant power of your bloodstream, and this translates into less free radical DNA damage. If you compare the antioxidant activity of white potatoes, yellow potatoes, and purple potatoes, Yukon Gold has about twice the antioxidant power of white, but purple has 20 times the antioxidants, which is comparable to what you might see in berries. Half a purple potato has about the same polyphenol antioxidant complement as half a cup of blueberries. Purple potatoes can increase the antioxidant capacity of our bloodstream, whereas straight white potato starch can act as a pro-oxidant and decrease it. Eat a purple potato, and over the next 8 hours, the antioxidant capacity of your bloodstream goes up. In contrast, if you eat white potato starch devoid of any pigment, you can end up worse off than where you started. OK, but does this translate into different physiological effects? Yes, indeed. Have people eat either purple potatoes or white potatoes for 2 weeks, and the purple potatoes improved a measure of arterial stiffness, whereas the white potato did not. And this translates into a drop in blood pressure, even in those already taking high blood pressure drugs, suggesting purple potatoes are an effective blood pressure-lowering agent. But what about the toxic glycoalkaloid compounds in potatoes? The toxic human dose starts around 2 to 5 milligrams per kilogram of body weight, and the lethal dose is not too far behind. The average amount of total glycoalkaloids in most potatoes, however, is less than 100 milligrams per kilogram. So at the average American weight of 180 pounds, a toxic dose is like 4 to 9 pounds of potatoes. What happens when you approach that? Possible nausea, vomiting, and diarrhea that could easily be confused with something like gastroenteritis or food poisoning. Some people can start to get sick at just 1.25 milligrams per kilogram of body weight, or even 1 milligram per kilogram. That would only be about 2 pounds of potatoes at the average American weight. It's also possible they could start accumulating if you ate them day in and day out. But what about those people who go on a fad potato diet and eat 3 or 4 pounds a day? They can do that without risking getting sick only if they peel their potatoes, which removes nearly all the glycoalkaloids. Emerging evidence suggests that higher daily intake of fiber-rich fruits and vegetables is associated with lower incidences of anxiety in adults, and at the same time, greater happiness, higher life satisfaction, and greater emotional well-being. So persuading people to consume more fruits and vegetables may not only benefit their physical health in the long run, but also their mental well-being in the short run. Fruit consumption, for example, has protective associations with leading killers like heart disease, stroke, diabetes, and cancer, as well as depression. The question is, why? Several different mechanisms have been proposed. For example, it may be the antioxidants and anti-inflammatory properties of produce, scavenging the free radicals that are involved in some of the inflammation associated with depression. If that's the case, what about just taking vitamin C supplements? The brain has some of the highest levels of vitamin C in the body, so the thought is if we take extra vitamin C, it may have some sort of therapeutic role in brain diseases, especially given it's not just an antioxidant, but also has other critical functions in the brain, such as helping to build neurotransmitters like dopamine, but you don't know whether it actually helps until you put it to the test. One study found a beneficial effect adding vitamin C as an adjunct treatment to an antidepressant, while another study found no benefit from vitamin C supplementation. So there are mixed results for vitamin C and depression. Here's another study that found no benefit when it came to depression, but those randomized to vitamin C instead of placebo pills did show a significant decrease in anxiety level. And this wasn't only seen in this study. The effects of oral vitamin C supplementation on anxiety in students. A double-blind, randomized, placebo-controlled trial. High school students were given 500 milligrams a day, or placebo. 500 milligrams of vitamin C is about what you'd find in 5 oranges, 4 yellow kiwi fruit or guavas, or 1½ yellow bell peppers. Within just 2 weeks, the vitamin C reduced anxiety compared to placebo, along with providing a significant drop in heart rate. Given these data showing vitamin C may have anxiety-reducing effects, researchers sought to find out if only a single dose could acutely affect emotional states. And indeed, within only 2 hours of taking some C, subjects experienced a significant drop in anxiety compared to placebo, though only among those who started out the most anxious in the first place. As a bonus, vitamin C supplementation may lower your blood pressure a few points, but whole fruits and vegetables can do the same thing, and may even do it better for those who need it the most. As I've shown previously, even just adding 2 servings of fruits and vegetables a day can have psychological well-being benefits within only 2 weeks, and you won't be put at risk of kidney stones like you would with vitamin C supplements, though that appears to be only a problem in men. A pivotal paper published in Europe more than a decade ago, entitled Healthy Living is the Best Revenge, found that adhering to just 4 simple healthy lifestyle factors, compared to none, could potentially have a strong impact on the prevention of chronic diseases. We're talking nearly 80% less chronic disease risk, slashing diabetes risk by 93%, dropping heart attack risk by 81%, and cutting stroke risk in half, and cancer by 36%. Think about what that means. The potential for preventing disease and death is enormous. In the U.S. alone every year, there are 500,000 heart attacks, 500,000 strokes, 1 million new cases of diabetes, and 1 million new cancer diagnoses. The message is clear. Adopting a few healthy behaviors can have a major impact. What are those 4 fabled factors? Never smoking, not being obese, averaging about a half hour of exercise a day, and adhering to healthy dietary principles, like lots of fruits, vegetables, and whole grains, and less meat. Follow those 4 simple rules, and boom, enjoy nearly an 80% reduced risk of major chronic diseases. What does that mean for mortality risk? A similar batch of 4 healthy behaviors combined predicted a 4-fold difference in total mortality, with an estimated impact equivalent to 14 years in chronological age, meaning the individuals were dying at such a reduced rate that it was as if they were 14 years younger. Finally, a regimen to extend human life expectancy. This commentary was in reference to this study, where a similar analysis of the impact of healthy lifestyle behaviors on life expectancies was made, but this time it looked directly at the U.S. population, which is of particular importance since Americans have a shorter life expectancy compared with residents of nearly all other high-income countries. The researchers concluded that adopting a healthy lifestyle could substantially reduce premature mortality and prolong life expectancy in U.S. adults. OK, but by how much? They estimated that adherence to a low-risk lifestyle could prolong life expectancy at age 50 by 14 years in women and 12.2 years in men. So if you're 50 right now, instead of only living to 79 if you're a woman and 75.5 if you're a man, taking just basic care of yourself could propel you to an average life expectancy of 93 if you're a woman and 87.5 if you're a man. The bottom line is it's never too late to turn back the clock. A midlife switch just to the basics, like at least 5 servings of fruits and vegetables a day, walking even like 20 minutes a day, maintaining a healthy weight, and not smoking, results in a substantial reduction in mortality even in the following few years. We're talking a 40% lower risk of dying in the subsequent 4 years. So making the necessary changes to adhere to a healthy lifestyle could be considered extremely worthwhile, and middle age is certainly not too late to act. As an aside, realizing the 12 to 14 years of added life study was based on data from health professionals, that got me excited about all the potential knock-on effects. If health professionals start getting healthier, they could become role models for more healthful living, and potentially save more lives than just their own. But that may have just been wishful thinking. Practicing what you preach can sometimes backfire. Evidently, displays of excellence can paradoxically turn off the very people you're trying to inspire. I mean, you'd assume that not being a hypocrite and trying to walk the walk would just lead to positive consequences, inspiring confidence in others, right? Don't you want a dance instructor who can dance, a music teacher who can play, a health professional who's healthy? But this simple intuition fails to take into account concerns about making other people feel inadequate. Like, you know how vegetarians are the targets of a surprising amount of hostility and ridicule? That's because they may come off as morally superior and make people feel like they're being looked down upon. There was an elegant demonstration of this phenomenon in this study, where principled deviants who take the high road threaten others' moral self-worth. This is what they did. Research subjects were asked to complete a racist task by an experimenter, and those moral rebels who refused to obey were cheered by observers, but were disparaged by participants who had themselves gone through with it, and for whom the rebel stance thus implied an indictment of their spinelessness. Isn't that interesting? So when doctors portray themselves as the picture of health, patients might think they're being holier than thou and unintentionally alienate people, potentially turning off the very patients who most need their help. You can see how someone with a weight issue might feel threatened and judged by a physician triathlete. But what are we supposed to do? We want healthy practitioners. Physicians who smoke are less likely to tell their patients to quit smoking. Physicians who are overweight are less likely to counsel their patients about weight. And physicians who don't work out are less likely to talk about exercise. What we can do to make patients more comfortable is emphasize that our role is to help people meet their own personal health goals, whatever they may be. Studies show that when doctors do this, take this approach, it increases the appeal of fitness-focused physicians to overweight patients. So we can then display exemplary behavior while at the same time not inadvertently alienate the very people who could benefit most from our guidance.